products, should this relate to healthy patients, those with comorbidities, age, any other parameters? And should it be different if this was meant to be a screening device or a diagnostic or monitoring device? I know it's a big question, and how would you do that if you think it should?
Well, I'm a big database maven, and for many years I had the largest clinical database of many types of data around. I had several petabytes of clinical data that we work with all the time from across the entire country. And I will say that when you get large amounts of data like that together, you can learn amazing things from what seem like they would be trivial variabilities and variations in the data. I mean, shocking how much can be learned. And we learn from that how much we didn't know about a field that we thought we understood very, very well. So the answer to that first part is yes, reference databases should be maintained, and it should be possible to, I believe there's some value in trying to standardize data elements, formats, if that's possible, but you can transform those things. Keeping that data accessible and visible so that we can go back and look at it later will allow us to improve it and get better over time. And there was a second part to that, which
the second part with, relating to the types of patients, the healthy patients who just are, like anything else, people are going to buy an app, they may not even be in the disease process.
so it's the screening versus
Comorbidities,
diagnosing,
age,
this kind of thing.
Screening versus diagnosing and then monitoring.
Well, clearly we don't have a very good handle on who our patients are who come in with sleep apnea and what their problems and concerns are. A little bit, it's all over the map, and we're talking about phenotypes. But phenotypes are a 19th century concept, and this is the era of molecular medicine. And so I would hope and expect that over the next few years, we will start to find biomarkers that will help us to do subgroup analysis on all these patients who come in with what we can today only classify relatively crudely. And we will quickly find that when a therapy works for a subset of patients, it's because it works for a subgroup of patients who all share a common etiology or a common pathophysiology, and the ones it doesn't work for have something quite different about them. And so capturing the maximum amount of data about these patients will allow us to marry that data up to some of these new markers that we have. And they may not be chemical markers, although I think a lot of them will probably be protein markers, but they also may be neurobiological markers, neurophysiologic markers, things of this kind. And of course, when we get to what people are referring to as AI, but we normally in the field think of as machine learning or deep learning, we may not be able to even say or know what those patterns are that allow a machine to predict something when we can't predict it. And we've run into this over and over and over. But that is the world that we're coming to, and all that is driven off data. So the answer would be yes, more of it, and without respect to whether people think they're diagnosing or screening.
I think there are certainly